Karlee Silver, welcome to Global Health Insights.
Thanks, Peter. Great to be back.
Yeah, it's great to have you back. We last spoke about a year ago, and I thought you made some terrific points. The one that really stuck with me was that in global health, innovation is needed now more than ever. And the global health system was under some pressure about a year ago, but it's under a lot more pressure now. And so I'm going to ask you about that. And also, Grand Challenges Canada, which you lead, has a new goal, a new strategy, and renewed funding. And so I want to ask you about that. And the reason I want to do that and why I think it's a broader interest is I think about Grand Challenges Canada in terms of the lessons that it's learning. I think about it as a pathfinder in global health and innovation. And so I think anybody interested in global health and anybody interested in innovation can learn a lot from the way you're thinking about things. And that's really the point of this whole podcast, because there's a lot more people interested in global health and in innovation than necessarily in any one organization. But I think the lessons are very interesting. So before we get to all that, though, I just wanted to recap for people, since it's been a year. Can you just say a little bit about what is Grand Challenges Canada, Karlee, and who is Karlee Silver?
That's great. Well, I'm looking forward to the conversation. So fundamentally, Grand Challenges Canada is an innovation platform. We find and support bold ideas that incorporate science, social, and business innovation in order to address some of the world's most challenging health and social challenges. We do this by early stage investing through seed funding. A large amount of our work is in transition to scale, so helping innovators think through not only what the solution looks like and testing that out, but also the path to scale and sustainability and the institutional kind of foundation that is needed in order to have sustained scale, sustained impact at scale from these innovations. We've been at it for over 15 years now, 1,700 innovations, and in about 100 different countries. Really chosen from where the best ideas exist. And then the impact of that has been enormous to date. And I can go into exactly what that is, but just as a teaser, 173 million people reached with life-saving or life-improving innovation to date.
Wow, great. And say a few words about Karlee Silver.
Me. Yeah. So I'm Karlee Silver. I lead Grand Challenges Canada. I have a PhD in genetics and immunology, and did work. My final kind of research work was in pregnancy and malaria. And I've been around GCC since it launched, thanks to kind of connections with you initially. And also thanks to your insistence, I stayed for longer than the 6 months that I initially had thought I was going to stay, and am now the CEO.
Well, thank goodness for that. I'm so glad you stayed. And implicit in that, obviously, I have a little bit of a bias here since I worked at Grand Challenges Canada, helped to co-found it, and worked for 15 years with you, and that was terrific. And so just to put that on the table, I am positively biased towards this whole thing, but don't let that dissuade anybody. So one of the things you said a year ago when we talked, Karlee, that really stuck with me is with the pressure on global health funding, global health ecosystems, innovation is needed more now than ever. You said that a year ago. And it was certainly true a year ago, but that pressure has torqued up tremendously, with the dissolution of USAID, with the U.S. leaving WHO, with all countries cutting back on development assistance, which peaked at about $80 billion a year, development assistance for health in the middle of COVID, and now has fallen to the high 30 billion range and falling fast. And so this is really a time of lack of development assistance in health funding, a time of real change and the focus on ecosystem and everything else. So let's just go back to that point that you made. If it was needed more than ever a year ago, it's certainly needed more than ever now. Why is that?
Yeah, absolutely. So often resource constraints is a big driver of innovation. When people can't do things in a way that they are used to doing or they want to do them because they're lacking time, money, energy, whatever, that often requires people to rethink and come up with new solutions. I'd also say that maybe the dangerous part about that is that people then kind of use innovation within strategies as a silver bullet, or thinking that if we just put this in and kind of go find some technological innovations, we will all of a sudden be able to solve a problem for much cheaper or faster. And I think one of the big critiques I have at the moment is that we're very focused on the technological or digital innovations, AI, et cetera. And I think there's real relevance for that. And we're missing a lot of the social innovations, service delivery innovations, and things that are probably where a lot of the advances in global health can be made at the moment.
Great. And just to follow up on that, and I agree with that kind of necessity is the mother of invention argument. One of the consequences of the drop in development assistance for health, which in the short term is super difficult, in the long term, I think is salutary, is a greater focus on countries themselves, country leadership, country accountability, even domestic finance. And we always said that, country-led, blah, 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 but I'm not sure we ever really meant it in the global system. But now that's where the focus is. That's where the focus has to be. And there's no choice in global health and for countries but to lead. How does that tie into your innovation is needed more now than ever thesis?
Yeah, absolutely. Well, but the same reason countries are now looking at, some countries dealt mainly in propping up their health systems with international donors. So I'd say like everyone in the system has been implicitly kind of holding up this facade, as you said, of country led. But really, like when the money was big enough, countries would kind of do what donors wanted to do. And I've heard that out of the mouth of ministers of health as well, saying, like, now we really mean that we actually have to take accountability. And what that is leading to is actually countries being much more, ministers of health being much more focused in their messaging and their signaling as to like, these are the key things I actually want to solve for, I need to solve for in order for our government to satisfy the needs of our citizens, which is fundamentally the job of a minister of health. And I think it's really powerful now that we can start hearing clear signals that then we can link to, okay, so how are we doing those things? How are we meeting that demand as clearly as possible and as efficiently as possible in ways that meet the constraints of a public health system, which is they're significant right now.
Well, that's very relevant context because what you're really saying is there's a shift in the dynamic from supply to demand in innovation.
Exactly.
And that is a great bridge to what I wanted to really focus on, which is that new Grand Challenges Canada has a new goal, a new strategy, and renewed funding. And congratulations for that. And I wanted to ask you about that basket of interweave things. I don't know which of those three you want to pick up and in what sequence, but can you just maybe start by describing a little bit about the renewed goal, renewed strategy, renewed funding? And then I want to dive deeper, especially on the strategy, because there's something very important in your strategy where I think you're really at the leading edge and where other people who are interested in innovation and global health could really benefit from hearing about your insights and experiences.
Yeah, thanks for that tee up. I mean, I'll deal with the funding part first. Yes, at the end of March, the Government of Canada, through Global Affairs Canada, reinvested in Grand Challenges Canada with a $200 million investment. That is renewing their commitment in a time that is, as you mentioned before, where ODA is falling, and Canada's also seen that those cuts find the international development spend. And so taking that with a huge vote of confidence and a huge, responsibility, I think, to be able to move forward on the new strategy, as you said. So thanks to the Government of Canada, our goal now is to be using that to leverage in other partners who are keen to move forward with the strategy. Our aim is by 2035 that we are reaching 700 million people with life-saving and life-improving innovation. As I mentioned before, we're at 173 million at the moment. So we've got some good ambition over the next 4 years in order to hit that with our actions and then see that play out over the long term with innovation. How we're going to do that? We have 4 strategic directions. The first is adapt. Second is accelerate. choreograph, and connect. And I'll just go through each of those. But the fundamental thing there is that we're shifting from the early stage impact first investment approach that we have in innovation. That's what we're known for globally. That's what all those innovation or all those results have originated from. And we're not completely abandoning that. But instead of that being our kind of key driver, what we're doing is shifting into a market shaping, system shaping organization that also funds innovation as part of that approach. So we're evolving from this high quality, disciplined, impact first innovation investor as the only thing we do to one that is also really focused on market shaping, systems shaping to help pull innovations to scale. And the reason we're doing this is because of the observation that as GCC has helped develop a pipeline of innovations that have matured over the last 15 years. We keep looking at what is the problem out in front of the most promising innovations that we support and help to address those problems, not just for those few innovations, but also in a way that helps the next 20 who are going to reach that problem have a more streamlined approach. And in the last strategic period, what we really were looking for was those big systems at scale, country governments, public health systems, multilateral funding organizations who are signaling that they wanted innovation. It was even happening then. It's happening even more now. Signaling that, but the way it was being done was chaotic and ad hoc. And the kind of smooth streamlining between like where are the actual markets and market signals and procurement mechanisms that tested innovations can be taken up. How do you make sure that the challenge that innovations, even though they are on a path to being faster, cheaper, better, can often have price limitations at the first instance that need to be solved with scale. And then the fact that there's a lack of coordination from all the actors that need to be addressing this problem. It's not going to be one organization, one institution, even the often talked about interaction between governments and innovators, that it in itself can be a very complicated engagement when you're talking about the need for procurement and accountability in a government system, but also wanting everything to be fit for the system. And so we've after looking for it for a while, we started to do some experiments in the last little bit that I can tell you about if that's helpful. And now we've landed on these 4 strategic directions that are going to map our path in the next 4 years. This is adapt, accelerate, choreograph, and connect. Adapt is all about us transforming GCC to help with greater support. It's more internal looking, but also involves ways that we are shifting some of the work we do, like seed funding, to partner countries or partner organizations that are closer to where these challenges exist. Second is around accelerate. That's the work we're known well for. How are we delivering and helping innovators build innovations so that they are scale ready? Choreograph and connect are our newer parts of the work. This is more where our systems play comes in. So you can think about our strategy as kind of half pushing innovations to scale and half pulling innovations to scale. The choreograph is really about orchestrating the systems changes that we need to make. There are 3 main barriers that we're trying to tackle in this. We've got weak demand signals and hard ways to get through procurement. We've got high cost of innovations and low investability. And then we've got a lack of system coordination. And so that choreographed part is where is GCC able to catalyze the actions of different players around very specific place-based scale opportunities in order to smooth that path and make sure that governments can actually address the challenges that they see in their own systems with innovation. And then the last one, connect, is really about where you started, which is that GCC is a learning platform. As we've evolved the platform to solve the challenges out in front of the most promising innovations, we have learned a lot. We have not done a great job of sharing those lessons in a ways that actually influence actions of others. And so the connect part is really about a lot more of that, synthesizing those lessons and sharing them with other actors who are at the forefronts of their own work in innovation so that we can influence so we can see greater impact in global health and more broadly.
Great. That's very, very clear. And I think where I want to drill in most is on the choreograph and those 3 barriers that you talked about, because that's the leading edge of your strategy. The connect is what we're doing here. The other stuff is what we
Accelerate is what
talked
we've been doing in the
and what we
past. Yep.
talked about last time, and I'd refer people to that podcast in July. So I'm going to zero in on choreograph, and I also want to ask you about that target to dig in a little bit more to that.
Sure.
But before I do those two things, I think what would help the most is if you could provide a concrete example that kind of illustrates one or more of those barriers that you described in choreograph, and how that can really amp up what you're doing, which is what we'll get to when we talk about the targets.
Yeah. So I'll give you two examples. One that is a lot further ahead, and it comes from one of the experiments we did in the last strategic period. This is work we did with Results for Development and Insight Health Advisors in several counties in Kenya. And the real problem we were trying to solve there was this understanding that counties were where the decision making on a lot of how the system works was devolved to these county level decision makers. But their ability to navigate the huge market of innovations at various stages of development and match those to their own needs and their own budget lines was very limited. And so Insight Health Advisors actually acted as a little bit of a guide, bringing the key decision makers from these counties together and walk them through different processes around how to think through which priorities are best for innovation to come in. What are the ways that existing procurement can actually pull innovations into the system? How do you rearrange the budget line items within their own kind of fungible accounts in order to address these? And how are they making the case for this? It's called a mountain model because there's kind of a visual of these intrepid voyagers who are having to climb up a mountain. It's not simple, but Insight Health Advisors was their guide. And together, the interaction between these four counties who were doing it was very rich, solving each other's kind of challenges, understanding where to use political influence and not. And it was a fascinating kind of process. But what we really cared about was, would it work? Once we got over the part where everyone was saying, hey, GCC, given you're funding this, what do you want us to pick? And we said, no, actually, we really want you to pick what your own priorities are. Once they really started believing that, we were away to the races. And that in itself is an interesting kind of symptom of the approach or of the system that was existing before. But a key win out of this is that one of the innovations that has been selected, which is Neopenda. It's a wearable newborn vital signs monitor that helps nurses or care practitioners in a busy hospital, busy clinic to actually be able to triage on the go. That was one where they had data of trying to enter different markets in the past. It was newborn health, and specifically decision-making things around newborn health was something that several counties had prioritized. Neopenda came in very strong on their procurement ratings. And Neopenda has seen the time to enter the markets of different counties be shrunk in half from what they were doing before. Not only that, but the counties themselves are feeling a lot of ownership over the solutions that they're putting in that system because they've chosen them explicitly to solve problems that they were kind of on the hook for addressing. And it means that there's a really strong kind of sustainability element to it. Most of the funding came from budgets that existed for facility improvement that already existed. And it wasn't needing to be kind of convincing anyone to come in. And that is part of the magic of being able to get to the right decision maker with some pot of monies in order to make it go.
That's a great example. Before going to another one, let me just dig into a few things. So just paint a picture of what that is. Is that like a wristwatch that monitors newborns, or what does that look like? Where did the Neopenda people come from? And how far have you gotten in terms of tracking that uptick in innovation, upscaling in innovation, and along the value chain actually to health improvements? So just three questions there about that example.
So it's a sensor that is stuck onto the newborn, and then it has a device that is centralized. So you can put multiple sensors on the same device. It will sound an alert when certain vital signs get thrown off because the baby is having trouble and needs attention. This came out of, I'm blanking, it's based in Kenya. That's the main place that we're doing it, and has links into the States, Chicago. And the last question you had was how much,
Tracking,
what's the
yeah,
impact?
yeah,
Yeah.
scaling and then health impact.
Yeah. So they've now entered into 40 different facilities across Kenya, reaching 5,200 patients.
Sounds good. Then you said you had a second example. Do you want to do that one?
Yeah, so the second example is one that we're doing right now, putting together. And this is one with Gavi and 500 Global, which is a private equity firm. And the point here is it's a financing instrument to combine both the concessional impact first funding and commercial focused funding rather than kind of blending them deal by deal. How is the instrument actually set up to have both sitting side by side and with both kind of fund managers incentivized to work across the whole? That's one that is going to help scale up innovations that help get more kids immunized. And so it looks a lot more at the systems, the health system and the primary care system that is necessary for strong vaccination rates.
And that's still innovations coming in the future.
Absolutely.
Yeah.
Yeah.
But very interesting. What's interesting about those two examples is the first one is essentially about procurement and
Mhm.
heightening
And
demand and
demand.
shortening procurement. And
Yeah.
the second one is essentially about investment.
Investment, although because of the Gavi link there, and this is what we were very excited about, that the demand for the specific innovation still comes from the country platform in the process of, as Gavi uses kind of the procurement process of other vaccines, that will be used as as a signaling mechanism for which innovations, which health system problems need to be best targeted, that certain innovations in the ecosystem can help address.
And Gavi itself has augmented its own demand signals through its Gavi Leap thing, where countries are selecting their own vaccines. So it's
Exactly.
all a piece. And
Yeah.
both those examples also had to do with system coordination. So it maps perfectly onto the barriers that you described. Great examples. I'm just going to ask you to talk a little bit about a third one because it's already at scale and already having health effects. And that's the M-Mama example that everyone loves in
Mm.
Tanzania, which does speak also generally to this demand side, government adoption, national scale storyline. Do you want to just go through that example?
Yeah, great. And it's an example that builds on the mountain model that was in Kenya. So it was piloted in Kenya first, and then it was adopted by the Global Financing Facility for Tanzania. And it was through that process that M-Mama was identified as one of the key innovations to pull to scale. And it was with funding from the Global Financing Facility that initial scale and embedment across the country happened. So it's all very kind of collective in terms of where it's going. And we're excited to be continuing working with the Global Financing Facility in its new strategy, where GCC was named as an innovation partner to find more examples of where we can work together to make that happen.
And it's a great example of system coordination. And also, there's a very significant ownership and a role for the government of Tanzania there, both in operationally now at national scale and financially.
What it is essentially an Uber ambulance. So it solves the problem that large geographic range in Tanzania, only 30 ambulances in the system. And so to fill that gap, the innovators looked at how can you use community drivers, essentially people with their own personal cars, train them to a certain point that they can be kind of first responders. When pregnant women can phone a hotline, 511, and they can get dispatched straight to a nurse. That nurse then figures out what's the need, what facility is closest that can serve that need, and dispatches either community driver or ambulance if there's one closest to the region. It's cut down on the amount of time it takes for people to reach quality care. Make sure that when they're arriving to the facility, they're ready to go. They know what's coming, and they have the people and the products needed in order to address the problem. And this is serving, I think it's over 1,000 women a month at the moment. And every time a community driver ends up doing one of these deliveries, the government of Tanzania actually pays them back into an account. It's about $1 for every transport. So in that way, it's Uber, but a lot of the innovation and kind of working with the public system involved spending very small amounts of money direct to citizens who are helping out. That was a big part of what unlocked the scale. Yeah.
It's a great example. And I read external review of this, an independent review that about a year ago that demonstrated that this example, M-Mama, was at national scale in Tanzania. It showed and validated exactly what you said, which is cutting down the transport time. And there was an early signal, not yet proven, but very promising, on declines in maternal mortality, because transport is actually, or lack of transport is actually one of the causes of maternal mortality. So there's a good example of, or a good leading example, I guess, of where you're going on
Yeah,
Choreograph, where you've
exactly.
got the demand side, you're pushing into the health improvements, and it kind of makes the point that country leadership, real ownership, including some financial skin in the game, and accountability is actually leading towards health improvements, and that's needed more than ever. Great.
And I would say on that too, Peter, that there's a power in innovations like that are actually helping resources be better used in a system. The M-Mama example, I mentioned the 30 ambulances that they had. When they started across the whole country, it was only about 1 in 10 transports that was being done by an ambulance. Now it's closer to 8 or 9 out of 10. And so the existing resources are being placed in more effective ways so that they can be used better for the intended purposes. So you're making more of money that already sits or investments that have already been made in the system. And it's also an interesting way that they've now seen, which facilities are persistently having problems and that they have a huge gap that's not the maternal part of the health equation, it's the newborn health of the equation. So it's leading them down a trail of that's where their next priority investments are going.
And to your earlier point, it's an example of service delivery innovation
Yep.
with a little bit of technology,
Yeah,
Uber
a
part.
data backbone, but
Yeah,
yeah.
it's an example of, I guess, enhancing accountability, and it's an example of improved system efficiency. So it's got a good financial uptick too. Great. So those are 3 great examples, and really, I think, bring to life what you mean by Choreograph and what your new strategy that you're heading towards is. I want to backtrack a little bit to the goals. So you said that over the last 15 years, Grand Challenges Canada has reached 170 plus million people.
Yep.
And you said
Yeah.
your goal is to bump that number up to 700
700 million. Yeah.
million people,
Yeah.
which is just over 500 million more. So you're obviously bending the curve there if you got 170 million in 15 years, and you're going to add another 500 million plus
Mm-hmm.
in, let's say, 5 years or
Mm-hmm.
4 to 5 years. So give
Are we
us your
doing
thinking about that. Yeah, how are you going to
Yeah.
do that? And I guess it builds upon the examples we were just talking about. But yeah, how are you going to do that? And that's so exciting because that's exactly what needs to happen.
Yeah. So how we're going to do that? I mean, we've mapped out which of the strategic directions we think these numbers are coming from. The bulk of them, as you can imagine, is coming from direct investments in transition to scale and scale innovations, both ones we will do in this time frame and ones that we have already done in the past and that continue to go along this growth curve. And so we are seeing, because we've been at this for 15 years and the pipeline is mature, we still reap the benefits of what has been invested in the past. So about 480 million people reached will be the target for our transition to scale and our scale work. And 120 million will come from existing investments that we've made in impact funds. So we've as part of you could think about this as some other systems work that GCC has done in the past of building out the impact investment landscape so that when innovations are graduating from the kind of support that we provide or others provide at a transition to scale level, there's actually financing vehicles that will pull them to scale to the next lens, to the next phase of investment. So these usually are kind of Series A, maybe Series B investments, Global Health Investment Fund, the Transform Health Fund, and Cross-Border Impact Ventures are 3 we've invested in. The last 2 of those are still very live and we're still seeing results emerge from that, and actually we'll see the bulk of the results emerge from that in the next 5 years. And then the last one is about 100 million lives reached through our systems work, and that is that choreographing and the connecting, and how we're seeing that our ability to intervene at a systems level to actually pull innovations to scale.
Yeah, super interesting. So, and the investment funds you talked about also can be thought about as part of Choreograph in the sense that they are one of those three roadblocks that you talked about. And so I'm just trying to do the math on the supply side and the demand side. So
Mm,
Accelerate, you said, was 400 and something million out of the,
yeah, so it's tilted about 2/3 to the demand side, and about 100 or 200 and some, another third on on the pull side, the demand side. Sorry, did I
yeah,
say
so
that right?
2/3 on
2/3
the
on
supply side,
supply.
1/3
Yeah.
on the demand side.
But I
And
will say that, like, to realize the impact on the supply side always requires a demand part. It's where the accounting gets hard, is how much have we intervened on those systems that were the ones to pull them to scale versus others.
right. So there's an
Yeah.
attribution issue,
Yeah.
demand. What you're really doing is being much more intentional and much more explicit about the
Yeah.
demand side and really
Yes.
understanding what that is, what those pull factors look like, and reinforcing them. And you're
Yeah.
going from a situation where you were doing kind of 100% supply and, let's say, implicit work on the demand side, or unstructured or less intentional or less purposive, to a situation now where you're 2/3 on the supply side, a lot of which is that snowball that's already rolling down the hill, and 1/3 being much more intentional and purposive on the demand side in exactly the way you described in terms of the barriers and exactly the lessons from those examples. And that's what's super interesting here, because that's the pathfinder part for others who are interested in
Yeah. And
and
I
it
would say every single one of those examples requires more than just GCC to work. By definition, it requires the government of wherever the based place we're playing in. Scale happens in a place. And it also usually involves many other forms of capital, other actors that can influence the system. So that's an open invitation, because we are experimenting, we are learning, and every single one of these experiments and these ways that we're intervening requires multiple actors. And so that's mainly, like, also in this moment of the money has gone down a ton. We're seeing a lot of interest from philanthropy to be really intentional about how they're moving their money, and doing it in a way that is much more at scale and much more directed at what they care about, rather than a lot of little things. Yeah. So they can tell the story at the end of the day, I think.
Yeah, and speaking of telling the story, you told it beautifully because that's what I love about GCC. You've got a very precise account of the model you're following or theory of change or however you want to call it, and the way you were able to stipulate clearly what the three barriers were and split accelerate from choreograph. And this is where a lot of people fall down, you've actually got the concrete examples to hang on that theory of change and show where it's working, where it's not working, how to learn, how to improve the pathway and learn and improve things overall for everybody. That's what I really liked about it. One little question before we close. What do you mean by reach?
Yeah, I knew you were going to ask this question. So for us, life reached is really what we mean by a person who gets a service or care because the innovation existed, care they would not otherwise have received without. So imagine if we go back to a vaccine, it would be any person who got the vaccine is a life reach. And then we go a layer deeper, which you were probing me on some and I didn't have it quite ready. But for each of these innovations, we have lives saved and lives improved. So the reach is the first thing. They have to have an encounter with a service that was made possible because of the innovation. And then we understand what is the number of, like, the reduction in mortality or morbidity that results from those encounters. So not every
Perfect.
life reach will be a life saved, but you need to reach a lot of lives in order to save lives.
Perfect. And to improve them. And people underestimate the value of morbidity in alleviating morbidity in innovation as well. Great. So that's terrific. I think we covered a lot. I just wanted to give you the chance to add anything else before we close. I think there's a lot of food for thought there for anyone interested in global health and anyone interested in innovation, even domestic innovation, by the way, something we'll talk about some other time in countries like Canada. But anything you wanted to say before we closed, Karlee?
Just to say thank you for the opportunity to talk about the new strategy. Given that we have the strategy landed and the money now behind us, the anchor funding behind us from the Government of Canada, we are all systems go. And so looking forward to working with many folks in the coming 4 years to make that 700 million lives reached a number, a target, a reality.
Great. Well, congratulations on everything you've accomplished, on what you will accomplish. And for our purposes today, on the thoughtfulness with which you're tackling this challenge. Innovation's tough, and it's
Tough.
easy to fail. And some failure's good, but you want to mitigate that risk and continuously decrease it. And that's exactly what you're doing through this learning. So thank you very much. And thanks for being with us. And I have a suspicion we'll probably talk again.
I'd love it. Thanks,
Great.
Peter.
Thanks, Karlee. Bye-bye.
Bye.